Chapter 7. Let's talk nutritional therapy. As we know, critically ill patients are at increased risk of malnutrition. Complications due to alterations in the metabolism, an increase in muscle protein breakdown, inflammatory responses, and muscle wasting can occur. And nutritional support is an important part of the patient's recovery plan. The alimentary canal may be compromised during critical illness, and that canal is comprised of everything from the mouth to the anus and facilitates digestion through both mechanical and chemical processes. Other accessory organs could include the parotid, submandibular, and sublingual salivary glands, the tongue, teeth, liver, gallbladder, pancreas, and each play a critical role in digesting and providing nutrients to the body. These accessory organs assist with absorption, digestion, as well as excretion. The parotid, submandibular, and sublingual salivary glands, tongue, teeth, and then the role of the liver in regulating appetite centers of the brain, secreting bile, and aiding in metabolism. Other accessory organs, like the gallbladder, release bile into the duodenum and aid in the fat digestion and absorption, while the pancreas secrete digestive enzymes that aid in the breakdown of macronutrients. It also contains those islet cells, with the beta cells secreting insulin and the alpha cells secreting glucagon. The vermiform appendix, which again, anytime you have lower right quadrant pain anywhere on NCLEX, they're probably leading you towards appendix. It functions as a storage and reproduction site of non-pathogenic bacteria and can also contribute to the normal flora of the large intestines. A thorough nutritional assessment can provide baseline subjective and objective data regarding the patient's nutritional status. It also determines any nutritional risk factors, identifies nutritional deficits, and establishes the patient's nutritional needs. Also identifies the medical, psychosocial, and socioeconomic factors contributing to this. It's no secret that food is getting more expensive, and unfortunately, this is a problem that's only going to continue. Part of that nutritional assessment would include things like the patient's medical history, malabsorption syndrome, laboratory values, including what's important, intake and output, daily weights, patient's gag reflex, dysphagia, adequate dentition, oral mucosa, hydration status, and even bowel sounds. We also want to assess things like their mentation. Is the patient overly sedated and not to be fed orally? Do they have chronic illnesses like MS that would alter their muscles ability? Are they overweight? Is a cancer patient? You may even include a speech pathologist to determine the patient's swallowing abilities. When calculating the patient's needs, we're going to look at their indirect calorimetry. I hope I'm pronouncing that right. We'll call it the IC. And the IC is the most accurate method of determining the patient's energy expenditure. Other standard calculations like predictive equations and simplistic weight-based equations. There are several members of the multi-professional team that may need to be consulted. Orders will be written by the intensivist, however, the clinical dietitian is usually involved in conducting these nutritional assessment and in making their recommendations. A clinical pharmacist with expertise in parenteral nutrition is often consulted in the orders of TPN, and a speech language pathologist may be consulted to evaluate the patient's swallowing ability and their ability to tolerate oral feedings. Quick quiz. The patient is intubated and hemodynamically stable with a gastrointestinal continuity. The team is determining when to begin nutrition. Based on the clinical findings, what type of nutrition would the patient receive and within what time frame? Would that be A, parenteral nutrition within the first 48 hours? B, parenteral nutrition within the first 72 hours? C, enteral nutrition within the first 48 hours? And D, enteral nutrition within the first 72 hours? That answer is going to be C. Patients who are not able to meet their needs orally are started on enteral nutrition in the first 24 to 48 hours, preferably within the first 24 hours. That's a long time to go without food. The patient is appropriate to begin enteral nutrition once a feeding tube is inserted, if it isn't already. Enteral nutrition is for any patient who cannot meet their nutritional needs orally and should be started on enteral nutrition, again, in that first 24 to 48 hours. And these deliver nutrients directly to the GI tract, with preferred methods including the lower risk of infection and also being less expensive. Other methods of enteral nutrition delivery would be trophic, which is beneficial in protecting the mucosal integrity, mobility, and immune function, and may be started and then advanced. We could also go look at targeted hourly rates with a goal rate, and this does not account for missed doses. There could also be a volume-based feeding, where the patient has a set goal volume and is able to compensate for gaps in therapy. For short-term nutrition, we're going to look at the orogastric versus nasogastric routes. Also, the gastric versus small bowel feedings. And in the case of long-term nutrition, for anything greater than 4 weeks, we're going to be looking at PEG tubes. We're going to confirm the placement of the tube that's blindly inserted devices. With NG tubes, there's that risk of sinusitis. There's also going to be post-pyloric feeding for reduced aspiration and regurgitation. And those PEG tubes that can be placed without general anesthesia. A jejunostomy tube, for example, can be placed only with a laparotomy. When assessing the patient's tolerance of enteral nutrition, we're going to be looking at abdominal distension, constipation, emesis, nausea and vomiting, and checking the gastric residual volumes. Other nursing considerations, always elevate that head of the bed to 30 degrees or greater. When you think about it, 30 degrees is not very far up. If you ever tried laying flat on your back and eating a cheeseburger, I can assure you it doesn't go well. You also want to avoid enteral nutrition interruptions. Flush it with at least 30 milliliters of water before and after each feeding to make sure we're keeping that tube patent. We don't want to have to be replacing it. And also collaborate with a pharmacist to determine potential considerations for certain meds, such as extended release medications and the absorption of the medication. Another quiz. A patient is receiving and tolerating enteral nutrition at the goal rate. The nurse is administering a medication twice a day that requires a holding the enteral nutrition for 1 to 2 hours prior to administration. How should the nurse proceed? A. Administer the medication as ordered. B. Consult pharmacy to change and determine if the medication could be administered via the IV route. C. Recommend the initiation of parenteral nutrition. Or D. Hold the medication. And that answer here is going to be B. If the medication can be administered IV, this would be the preferred option until the patient's no longer taking enteral nutrition. Though the nurse could administer the medication as ordered, it could have detrimental effects on the patient's nutritional overtime. On the other hand, parenteral nutrition is used for patients who are unable to tolerate enteral feedings, including things like GI obstruction and discontinuity. The goals are not met for enteral nutrition or oral nutrition for an extended period of time, such as over 1 week. It's also for patients who are admitted very malnourished or at a high nutritional risk. You want to start immediately. Both the timing of the initiation of parenteral nutrition and the clinical benefit are controversial. The factors for deciding therapy to use are based on the length of time the patient will receive parenteral nutrition, the patient's vascular access history, venous anatomy, and the coagulation status related to the central line site selection. There are different routes and types of parenteral nutrition. With the feeding delivered directly into the bloodstream, there's that total parenteral nutrition, which is a hypertonic solution and requires a central venous access. It also comes with an increased risk of hyperglycemia, so make sure we've got that patient on careful, regular blood glucose monitorings. There may also be peripheral parenteral nutrition, which is isotonic. While not indicated in the adult population, because it does not provide enough nutritional support, it may be initially prescribed while they get that central line placed. Parenteral nutrition is an infusion of that nutrient solution directly into that bloodstream. A central line catheter is placed into the vascular system with the distal tip within the superior vena cava, right atrium, or inferior vena cava. The peripherally inserted central catheter, like a PICC line, is an external tunnel catheter or a subcutaneous port. The placement of these lines is verified by a chest radiograph. And there are 2 options for parenteral nutrition administration. That could be peripheral parenteral nutrition, PPN, or total parenteral nutrition, TPN. If you ever see a TPN that's milky white, it has lipids infused. And it's infused within that TPN to prevent essential fatty acid deficiencies. And consider other medications that use lipids to prevent hypertriglyceridemia. In this case, this patient's severely malnourished, and we're adding extra fat to their diet. Nurses monitor for a variety of complications. Malnourished patients are at risk for refeeding syndrome, which leads to sudden electrolyte abnormalities and fluid shifts. There could also be glucose and electrolytes like sodium, chloride, potassium, and magnesium, which are monitored regularly. Others must be diligent in monitoring glucose levels in these patients receiving TPN. The administration of insulin when TPN is temporarily discontinued can lead to hypoglycemia, especially when those patients are on a regular rate of TPN. The body becomes accustomed to having that slow infusion of glucose, and when that's discontinued, their blood sugar could drop rapidly. In the case of the patient's nutrition care plan, we want to determine the patient's calorie, protein, and fluid needs. We're going to set intake targets as well as the route of administration. We also want to set measurable short and long-term goals, including things like weight gain and stable laboratory values. Quiz time. A patient with a feeding tube is prescribed an oral medication. What would be the best action for the nurse to take? That be A, crush the medication and administer with the tube feeding. B, contact the pharmacist to check the medication and obtain it in liquid form. C, melt the medication in 30 milliliters of water and administer through the feeding tube. Or D, turn off the feeding for 30 minutes and have the patient swallow the medication with a glass of water. That answer here is going to be B. Contact the pharmacist to check if the medication and obtain it in liquid form. Enteral nutrition is the preferred mode of nutrition for a patient unable to take nutrition by mouth. Always remember, we want to confirm the placement of that enteral tube with radiographic confirmation if blindly placed prior to initiating the enteral feeding. We want to make sure it's going to the right place. We also want to reassess that placement every 4 hours by examining the external tube length. Has it moved? Has it shifted? You also want to carefully monitor the patient's tolerance. Don't routinely monitor gastric residual volume. Monitor for intolerance by assessing gastric distension, constipation, and nausea and vomiting. And also be aware that narcotics and analgesic medication may slow the gastric motility, increasing their risk of intolerance. But anyway, that's all we got for this chapter. I'll see you in the next slides. On to my favorite chapter, dysrhythmias.